masuk link tersebut. Kita tunggu ya sampai sudah masuk. Jadi silahkan teman-teman yang hadir di sini bisa langsung masuk ke link kuisis yang ada di chat untuk mempersiapkan mengikuti kuis ya, berhadiah ratusan ratusan ribu rupiah ini. Ya, tapi namanya jangan nama samaran ya, nama asli ya. Nah, walaupun nama pendek misalnya Mas Yusuf boleh ya, Bu Yusuf boleh. Penting nama beneran gitu. Jadi biar kita nggak bingung mencarinya. Ya. Silakan, kami masih tunggu. Ada suara. Nanti pas mulai. Silakan, masih ditunggu. Bisa pakai link yang ada di chat atau masuk ke dalam website kuisis, kemudian memasukkan angka kode permainan ya. Silakan. Gunakan nama sebenarnya ya. Jangan nama peliharaannya gitu ya. Apalagi nama mantannya ya, jangan ya. Sudah 23 dari 78. Ini pada peserta yang masuk Mas? Enggak. 78. Belum ada yang masuk lagi ya. Silakan teman-teman mengikuti. Kuis ini tidak, ya panitia boleh ikut tapi tidak ini ya, tidak berhak menang ya. Walaupun mungkin panitia juga nggak ngerti jawabannya apa gitu. Panitia boleh ikut tapi tidak berhak menang. Kalau mau ikut seru-seruan boleh ya. Nanti akan kami tentukan pemenangnya siapa saja. Silahkan teman-teman, Bapak Ibu sekalian yang mau ikut ya, boleh ikut untuk kuis biar seger nih sebelum memulai di pertemuan selanjutnya. Jadi yang baru bergabung masih dibuka kesempatan ini ya untuk mendaftar ikut kuis ya, berhadiah ratusan ribu rupiah ya. Saya kira ratusan juta ya. Ratusan ribu rupiah ya. Silakan masuk, bisa masukkan kode 268515 pada web kuisis atau di chat ada linknya ya. Boleh mungkin di-share kembali linknya panitia. Di reshare biar ada link yang muncul lagi. Klik linknya bisa langsung masuk ya. Menggunakan nama sebenarnya ya. Jangan nama siapa-siapa ya. Masih ada waktu ya sebelum kita mulai. Ini peserta yang tergabung ada 86. Nah, ini tapi yang masuk ikut kuis baru 36. Ini akan hadiahnya kepada 5 besar ya. Jarang-jarang ada hadiahnya sampai 5 gitu ya. 5 orang pemenang gitu ya. Pertanyaannya sangat-sangat menarik gitu ya. Jadi teman-teman bisa mengikuti ya. Silahkan, masih ditunggu. Masih ditunggu nih, pesertanya 86, yang join baru 37 ya. Atau mungkin lagi berbuka puasa? Oh, belum ya, belum waktunya ya. Oke. 37 ini yang daftar. Kita masih tunggu ya. Paling enggak ya 50 ya. 50 orang kita mulai ya. Silahkan masih ditunggu ya. 41 ini yang sudah bergabung. Masih belum quorum ya, belum setengahnya. Masih ditunggu. Kalau semakin banyak semakin seru. Memperebutkan hadiah yang dipersembahkan oleh Magister Farmasi di siang hari ini. Lumayan kan? Nanti bisa telepon-teleponan pas Lebaran menggunakan pulsa yang dikirimkan oleh panitia ya sebagai pemenang. Jadi bisa telepon-telepon pas Lebaran ya, tanpa mikir beli pulsa. Atau beli kuota juga bisa ya, beli kuota. Ya. Ada hadiah menarik. Silakan, baru 44 nih. 50%. Yo, yang baru datang silakan bisa join langsung ke kuisi. Kemudian masukkan kodenya atau klik link yang ada di chat ya. Silakan bisa klik link yang ada di chat ya, yang disediakan oleh panitia. Kita akan mulai 3 menit lagi ya. Ini sudah banyak ya, 46. Kita akan mulai 3 menit lagi. Kuisnya nggak lama, cuman satu pertanyaan hanya 20 detik, tapi cepat-cepatan ya. Nah, jadi teman-teman bisa langsung ya, cepat-cepatan. Yang benar siapa? Ya. Kuisnya pertanyaannya diambil dari ini ya, kehidupan sehari-hari dan ensiklopedia yang ada di Magister Farmasi. Gitu ya. Diciptakan tadi oleh staf jurusan farmasi gitu ya, pertanyaan-pertanyaannya. Jadi cukup menantang pertanyaannya. Saya jadi kayak siaran radio ini. Oke, sudah 50 ya, 2 menit lagi kita mulai. Yang belum bergabung silahkan bergabung, waktunya masih ada waktu. Ya, pakai nama ya. Boleh kalau pakai NIM boleh ya. Ini jelas NIM-nya siapa ya, bukan NIM temennya ya. Silakan. Namanya 53 ya, 2 menit lagi. Kita akan memulai. Oke. Ya, 1 menit lagi kita akan mulai. Setelah itu di stop share ya. Enggak. Terus nanti misal kita mulai, kita bisa langsung mulai. Silakan masih lanjut lagi. Kalau punya 2 akun bisa pakai 2 akun ya. Oke, handphonenya 2 gitu. Sudah tahu dua-duanya dapat gitu kan. Kayak 2 akun. Fake account satunya pakai yang asli gitu. Oke. Oke, yang belum bergabung saya kasih waktu sedikit untuk kesempatan terakhir untuk bergabung. Bisa melalui link yang ada di chat telah dibagikan oleh panitia, dan juga bisa masuk ke kuisi, kemudian masukkan kode 268515. Ya, jadi masukkan kodenya. Kita akan mulai ya dalam waktu yang segera, karena sudah hampir 12.50. Oke, kami akan mulai untuk kuisnya. Mohon 3, 2, 1 mulai. Dilihat device-nya masing-masing. Ya, pertanyaan kedua ya. Asal institusi dari bicara tadi dari mana? Silahkan. Lanjut, ya ini pertanyaan ketiga. Apa program studi terbaru dari jurusan farmasi ini? Masih baru lahir ini. Apa program studinya? Nah, terlihat masih ya, Dian NS Sarah dan Lianur Hasanah masih memimpin ya. Betul semua ya. Lanjut pertanyaan selanjutnya. Tahun berapa program studi magister farmasi UI ini mulai dibuka ya? Nah, saya yakin ini banyak yang benar ya. Masih ya, belum ada perpindahan nih di papan atas ya. Papan tengah mulai menyusul Yusuf ya. Wah, masih ada yang menjawab tidak pas ini ya. Oke, nggak apa-apa. Kita berkenalan di sini ya. Lanjut pertanyaan selanjutnya. Nah, ini yang paling seru nih pertanyaannya. Apa keunggulan pengembangan riset di magister farmasi ya? Lihat leaderboardnya masih ya belum. Wah, Mbak Nia Nur Hasanah sudah menyusul ya dengan angka yang sama gitu. Wah, nggak ada yang milih mahal ini ya. Berarti bukan Sule geng ya. Maha tahu, ada yang maha tahu. Ini ada yang suka nonton Mahabharata nih. Lanjut. Wah, ini nih siapa nih nama kaprodi Magister Farmasi? Semoga tahu ya. Ini pertanyaan yang sulit ya. Wah, Yusuf luar biasa ya. Naik terus. Ya. Wah, ini cukup berimbang karena mungkin memang belum pernah jadi kaprodinya adalah Ibu Suci Hanifah ya. Lanjut pertanyaannya. Nah, apa ini konsentrasi di Magister Farmasi? Sains klinis, sains ekonomi, ekonomi syariah, atau sains dan hukum? Sudah benar semua ya ini. Lanjut. Ya, sains ekonomi enggak ya, kita sains klinis ya. Nah, ini nih. Kapan nih tahun 2022 mulai PMB nih ya? Tanggalnya tanggal berapa nih? 1 April, 11 April, 21 April, atau 31 April? Mulai buka PMB nih. Jadi bocorannya PMB-nya sudah dibuka ya. Jadi kalau misalnya merasa sudah sesuai, bisa mendaftar. Wah, ini disalib Mbak Diani Dasar Sabila, langsung nomor 1. Ya, yang jawab benar adalah 11 April ya, bukan 21 April. Silakan pertanyaan selanjutnya. Apalagi yang daftar menjawab 31 April ya, kan nggak ada di kalender. Nah, apa keunggulan lain yang disiapkan Magister Farmasi? Nyiapin lulusannya dari polisi, jadi kapiten, YouTuber, atau jadi kaprodi? Wah, benar ya. Apalagi ingin jadi polisi boleh, Pak, boleh. Tapi kita nggak menyiapkan ya. Lagi jadi kapiten ya. Oke, lanjut. Nah, yang terakhir nih, ini pertanyaan yang luar biasa. Apa sih beasiswa yang diberikan oleh Magister Farmasi ya? Pertanyaan terakhir. Nah, pertanyaan terakhir ini jawabannya semuanya benar ya. Jadi kita punya beasiswa alumni UI. Kalau yang alumni farmasi UI, beasiswa asisten riset mungkin biasanya dibuka lowongan dari dosen-dosen di farmasi. Kemudian ada preseptor. Kalau misalnya di sini ada yang preseptor, kemudian ada yang pengurus aktif IAI. Bahkan kita juga memberikan penghargaan untuk dapat beasiswa di Magister Farmasi. Begitu ya, terima kasih atas kesempatannya siang hari ini kuisnya, semoga membuat sedikit melek ya. Ya, kalau tadi yang sudah berbuka puasa minum gitu ya, lebih segar lagi gitu ya. Terima kasih, sampai berjumpa di lain kesempatan. Salam.
Era Industri 4.0 mengarahkan pada pengembangan teknologi kesehatan menuju ke personalized medicine dan nanobiotechnology yang memanfaatkan artificial intelligence serta penggunaan mahadata dalam memberikan pelayanan kepada masyarakat. Untuk mengantisipasi perkembangan ini, jurusan Farmasi Universitas Islam Indonesia memberikan kesempatan untuk menjadi bagian dari antisipasi perkembangan ini untuk melanjutkan studi ke jenjang S2 Farmasi di UI. S2 Farmasi UI memiliki keunggulan pada pengembangan farmasi berbasis data science atau mahadata. Kurikulum ini disusun untuk merespon dinamisnya perkembangan ilmu dan teknologi, terutama dalam bidang kesehatan dan farmasi secara khusus. Sehingga model pembelajaran yang dirancang dalam kurikulum akan diupayakan dapat memfasilitasi transfer ilmu dan penguasaan teknologi sesuai tuntutan revolusi industri 4.0 dan society 5.0. Pemanfaatan mahadata ini juga akan memberikan manfaat untuk pengolahan data dalam membuat kebijakan dan meningkatkan kualitas pelayanan. Selain keunggulan utama, S2 Farmasi UI juga menyiapkan mahasiswa sebagai seorang pendidik dengan menyiapkan pembelajaran pedagogik yang diperkuat dengan kemampuan dalam menyusun kurikulum perguruan tinggi.
Oke, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and welcome back. Yeah, before we start our webinar, I would like to welcome Dr. Hannah Morrissey and Professor Patrick Ball from Wolverhampton University. Hello, Dr. Hannah and Prof. Patrick Ball.
Hello, good morning, good afternoon to you, good morning from here.
Yeah, good afternoon from Yogyakarta, Doctor.
Hello.
Okay.
Hello from me.
And let's jump into the next agenda. The next webinar will be delivered by Dr. Hannah Morrissey and Professor Patrick Ball from Wolverhampton University with the theme about hospital pharmacy service compounding sterile preparation. And our second webinar will be hosted by Gita Laila Rahmayanti. She is student of Pharmacy International Undergraduate Program Universitas Islam Indonesia. Gita, time is yours.
Thank you, Mbak Husna. Before this, can you hear my voice clearly?
Yes.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hello, good afternoon, everyone. Welcome back to this webinar, The Role of Pharmacists in Sterile Compounding and Therapeutic Drug Monitoring. In this second section, it is my pleasure to welcome our speakers and all of the lecturers of Pharmacy Department of Islamic University of Indonesia, as well as the entire audience on this webinar session. Compounding remains a key component of the pharmacy curriculum. In hospitals, pharmacists compound medicines to improve access for patients who would otherwise not have the medicine in the suitable formulation. Compounders in drug compounding must continue to develop their knowledge to produce better quality and good efficacious drug preparation. Okay, ladies and gentlemen, please allow me to introduce myself. My name is Gita Laila Rahmayanti. I am a student from International Program of Pharmacy in Islamic University of Indonesia. Here, I will accompany you guys as a moderator in this webinar session. In this session, we will get an explanation by two speakers. They are Dr. Hannah Morrissey and Professor Patrick Ball. So welcome, Dr. Hannah and Professor Ball.
Thank you.
Thank you.
Thank you. Would you like me to share my screen now?
Yes, but before that, I will introduce you first to the audience, maybe.
Yeah,
okay.
That's fine.
Okay. So
or if you like us to introduce ourselves, we can do as well, if it's easier for you.
Okay. Okay, maybe you can introduce yourself.
Okay,
Thank you.
if it's easier.
Okay.
Yeah, so Patrick, do you want to go first?
Hello, I'm Patrick Ball. I'm Professor of Pharmacy Practice at the University of Wolverhampton. I've been a clinical pharmacist since before most of you were born. Graduated in pharmacy in the UK in 1975. I've worked in New Zealand and Australia, and pharmacy as a career has taken me all over the world, including to your university in Indonesia, and given me wonderful opportunities. If I had my life again, would I be a pharmacist again? Definitely.
Okay, so it's me. My name is Hannah Morrissey. I'm a clinical pharmacist specialized in chronic disease management and mental health. Like Patrick said, we've been all over the world with pharmacy. So I think it's the profession will take you where you want. By doing the right things, by being professional, and yes, the world is your oyster. I think one of the things made us more known around the world is our research. So I will encourage all of you, don't restrict your life to just a practice. Look around, do more than just everyday work. And this will make you really very good pharmacist.
Okay. Thank you, Dr. Hannah and Professor Ball. So before the material explanation begins, let me inform how the presentation will be going on. The first is Dr. Hannah and Professor Ball will be invited to present the material about hospital pharmacy services, compounding of sterile preparation for approximately 1 hour and 30 minutes. And after that, there will be a question and answer session or discussion session, and followed by conclusion. Okay, so before we go into the material, please all the participants to activate their camera, and please prepare your note and question, because in this section we will get a lot of interesting information, and please pay attention. Now, please allow me to welcome the speaker, Dr. Hannah Morrissey and Professor Patrick Ball, to deliver their presentation. Dr. Hannah and Professor Ball, the time is yours.
Thank you very much. I'm just sharing my screen now with you guys. Okay, so because when I share my screen, I will not be able to see your questions. So while I'm talking, Patrick will look at the chat, and when he's talking, I'll be looking at the chat. So I thank you very much for inviting us. I think this topic is very close to my heart. I think sometimes the pharmacist takes this lightly and think that it is just mixing two things together will produce the magical remedy, and patient don't need to worry about anything. But compounding, especially aseptic, is very, I will say it is the profession or the type of practice for a very, very particulate and perfectionist person who do not allow mistakes and kind of try to elevate above human error to minimize it or reduce it to almost nothing. But one person can't do that. This is why it's usually kind of teamwork through governance, through quality assurance, through quality control, in addition to the person who's doing the compounding. So let us see how the journey starts. So I put for you some learning outcomes here, just in case you want to do any reflections on it, to just help you through it. I will start first with the contamination and sterilization process. So if we looking at the clean room as such, I'm just moving you around, guys, so I can see my screen clearer. So if I'm looking at the clean room, when we say it's a clean room, it's not just a room. It's a controlled, designed for purpose room where everything contained and controlled. And this is the word the containment come from, which is, it's a process where we really need to be able to prevent any contamination, but at the same time, make sure that the product is started and finished in this very tightly controlled environment. If we look at the contamination, contamination is something you contaminated immediately, or cross-contamination, something contaminated because whatever you added to it was contaminated. So you done all the right thing, but you added something was contaminated previously. I think we heard the cross-contamination word a lot during COVID, but at the same time, believe me, it is very applicable also to your aseptic process, where a little thing you can do can cross-contaminate your products, the product you want the patient to use safely. So we look at contamination. It's some terminologies and definitions you need to keep in your mind: what clean room is, what containment is, and contamination and cross-contamination. So why sterile products are different than aseptic product? If we look at the sterile product, sterility is a complete absence of microorganisms, and usually done or accomplished from the beginning or during the preparation of the product which we packed in a manufacturer pack. If we have any contamination in any product, we know that it can kill people, especially if it's injected. Why? Because it's straight away into the circulation in the blood and can cause the largest possible damage. If you want to determine that product is sterile or not, you can't test it in the middle because you may miss something happen towards the end. So we usually test it in the end product. But again, if I test one or two, it doesn't tell me that the entire batch I produced is sterile. It's just to tell me that the bottle I tested is sterile. So again, it is a kind of a generalization that we can't say that the entire product is sterile and the whole entire batch is sterile. However, there are things we can do in the middle that can make me trust that the random sample I'm testing at the end telling me that the whole batch is sterile. And we will come to this towards the end. So terminal sterilization is what we do in a manufacturing. It usually involve a very closed system and always involve very large heat. And it started from sterilizing the containers. A product can sustain or tolerate heat. So everything is at temperature where microorganisms can survive. So from the bottle I'm starting with to the product I'm filling in the bottle with, to the cork I'm using to close the bottle and to finalize my product. Everything is going through this terminal sterilization in closed system. Not every product can go through this. So for example, give me example in the chat. What products we can't use using this way? Okay, don't be shy. I don't like to be talking at you for an hour. I would like to have conversation with you for an hour. Okay. So I can't see anyone entered any answers. What products can't sustain heat, high heat? What pharmaceutical products you think can't be sterilized in such a way? Think about biologicals. If you kill microorganisms by heat, you will kill any biological based products as well, isn't it? Or you will make it ineffective. So please start the conversation. So aseptic products though are different. Why? Because they are not made in a manufacturer. They usually made in a hospital or made by contractor who simulate your hospital compounding room or clean room, or made by a compounding pharmacy who also have a clean room. So it is not terminally sterile, but use products when they were terminally sterile, so or filtrated to be sterile. And we will know what I mean by filtration. So a use product as a starting point where all those products were sterile, and then we put them together to produce something new, where we controlling any contamination. So in a clean room, in another word, in containment, while we're preventing contamination, while we're preventing cross-contamination. Start with the sterile products, putting them together under certain environment to still produce a sterile, but because it is not terminal sterile, the final product, we call it aseptic. So it's another word of putting a sterile product together to produce something sterile. Okay, but it really dependent on how we containment control based on the environment we're producing this product in. So just one example, if you have intravenous bag, say sodium chloride, I didn't add anything to it, there is possibility that there is 0.4% contamination in it. It doesn't have to be microorganisms or particles, but it might have around the 0.4%. If I just add one additional product, you know, when you're people in hospital and the nurse come to add one product into the bag, the introduction of more contamination will for sure increase, and increase by almost double, increase to 0.78%. And if I add another one, I again the double one. So I not doubled only the 0.4, I doubled the 0.8. So this very, very small percentage, it might not cause any harm to the person. However, we know that every time we add product to intravenous bag in open environment, we introduce some contamination. This is why for vulnerable patients, or when the product is very specific, we try to do it in clean room to reduce this contamination, because we have unique patient. So we don't want this patient to be exposed to a higher contamination rate. what contamination is. It can be living, it can be pyrogens, it can be chemical, it can be inert or non-viable contamination. If it's viable, we're looking for bacteria, we're looking for fungus, we're looking for yeast, and it might be also viral. But we will talk about virus by itself in the next screen. The likelihood for contamination usually is bacteria and yeast. Why? They can live without human for a longer period of time, but also they can contaminate anything where they can find nutrition and survive without the human being life exist. So they can survive without us, and they can be in the water, in the soil, or over our skin. So it's the most known contamination, keep in mind, will be microorganisms. Okay, and the most common three are cocci, bacilli, and vibrio, or you can also add the spiral bacteria. Okay, they can cause diseases, number one, but also they can cause bacteremia or septicemia, and then the person can be at high risk of lifelong complications or actually die. Virus is different because they need a human being to survive. Even COVID, it didn't survive for more than 24 hours, 72 hours on services.
72.
72 was the maximum on services. So even if they survive, the likelihood that they survive for in fluids in preparation is small. However, when someone have viral infection, they are still not allowed to enter the clean room. We don't allow them to be involved in manufacturing any of aseptic products. Just to be safe, because as you know, we don't know enough about viruses and how they mutate, how they survive. So preventing the unknown is still as good as preventing the known, which is the bacteria, fungus, and mold. So they will not be allowed in a clean room. This is just a test being done to show you if you sneeze with your mouth and open and your nose uncovered, the amount of particles you spray around is, as you can say, massive, and it shoot for distance long enough. You knew it from COVID, it can be up to 2 meters. If the person try to control, cover their mouth and their nose when they sneeze, still there is droplets coming out, but it will not shoot for long distance. Facial mask, as you can see, for sure, will reduce it to kind of the bubble around the person. Patrick, you can add.
I'm going to say, you can look at the COVID data worldwide. The widespread wearing of masks dramatically reduced across the whole world transmission of common rhinoviruses, other upper respiratory viruses, and the flu virus.
All urn and breast droplets, yeah.
Yeah, so wearing masks dramatically reduced transmission of not only COVID, but all these other viruses as well.
All airborne, yeah. Okay, so pyrogens, they are not bacteria, but they are parts of. So they can be part of decayed bacteria, remnants of destroyed bacteria, but they still are foreign bodies. They still can carry or be mixed with living microorganisms, and they still can cause fever and also can cause, think about when you have a foreign body entering the circulation, the body will react to it because the body don't know it's a bacteria, virus, or just a dirt or a particle dust. The body will react to it to try to contain it. And the reaction usually will be by initiating the inflammatory response. And the inflammatory, sorry?
And the reaction will be proportional to the amount of pyrogen introduced.
Yeah.
It can produce a very mild pyrexial reaction, a slightly raised temperature, all the way through to systemic inflammatory response syndrome, which can be absolutely life-threatening.
Which can trigger the inflammatory shock, and from the shock, septicemia again can happen. So we don't take it lightly either. But also you will see when you start to do, I don't know if you have practicals to do aseptic products or not, but if you do, or if you are going to have simulation, you will see we clean things in a clean room multiple times, but also we clean it to make sure that everything as close to sterile as possible. So we use a lot of chemicals. So the type of the chemicals we used is very important as well. And we usually use 75% alcohol rather than using detergent or any other chemicals. Why? Because we know 75% alcohol can't be used by bacteria as nutrition, but also evaporate. And we also say we wait until the alcohol evaporate before we open any vials or start any manipulation or any compounding process. So that
for the microbiologists amongst you, the addition of the water means that when the alcohol, which has the action of cleaving disulfide bonds in the bacterial cell wall and causing the bacteria to break down, if you have only alcohol, when the alcohol evaporates, the bacteria can survive. If you have the water there, it hydrates the broken bonds and prevents them from reforming. So you actually get a better kill with diluted alcohol than with neat alcohol.
Or absolute alcohol, which 95%. So 70 to 75%, this is the best cleaning chemicals you use in a clean room. And then we got our most offender is a non-viable, which is the dust or droplet, which it's a very good media to carry microorganisms or by itself to cause damage. So when we talk about the design of the clean room, we will also be talking about how much it is essential to reduce the amount of particles in the room where you're conducting your compounding for aseptic products. So it can be dust, it can be fiber from our clothes or the tissues or the towels we use to clean. It can be paint flakes, it can be metal filling, rubber, glass, you name it. So everything listed in this table, it will be our job to totally eliminate or at least reduce in a clean room environment where we conduct our compounding. Okay, so remember these things because I will ask you some questions at the end. And if you look at how visible these contaminants to us with our eyes without microscopes, not all of it and not all the sizes will be possible to be seen by our eyes. So anything below 0.3 or 0.5 really, we will not be able to see. So some dust, some smoke, some skin dropping, we will not be able to see with our eyes, but they may still falling and available in the clean room. So we have to do other things, like the way we dress and the environment we will compound in, to make those which we also can't see. You can see dirt on the bench and you clean it, or dust, but if you can't see it, you can't clean it. But the best thing is to clean and contain, regardless, to make sure that what you can't see will also not reach your product. So when we do any aseptic dispensing or compounding, it is defined as a product, final product, which starts by mixing products were finished as a sterile, regardless of the sterilization methodology, and also will utilize a sterile transfer system, open or closed, and I will explain to you the difference between the two. Open, you manipulate it by hand. Close the system, you only involved at the beginning, at the end, and the rest done by machines. So regardless of open or closed system, it has to employ a sterile transfer system, but also use the validated process. So you as a person will be also validated. Why? Because we know that human beings differ, but also if I know something, look at your driving, you do all the right things when you are going to set your driving test to get your first license. But 15 years later, if you go and reset this test again, you will discover that you have a lot of bad habits. And human beings also do this. So we will need to validate the people process frequently. So we need to know if you're doing the right thing when you mix your products, when you transfer them, when you check your final product, but also if you have the skill and the ability to do so without lapses, without error.
So this is one of the other things that, other than in an emergency, you never use untrained operators in clean rooms. You always have to train and validate all staff working in a clean room area.
Yeah. Absolutely. So to prepare, why we're using the aseptic process, because the manufacturer sometimes, limited to what they can produce. They make more money of producing 1 or 2 strengths of any product rather than producing 10 or 20 different products to suit every different human being. So sometimes whatever available on the shelf either need to be diluted, need to be administered over a longer period of time because the person kidneys or livers are not good enough, or their age, or the need, the condition. It might be unstable, so I can't pre-dilute. I have to dilute and prepare just before administration, or I need to individualize it because the person is too small or too big or too old or too young. I also need to, I can't sterilize it, so I can't have any preservatives in the product I'm using. So I will have to do it immediately after use, or it's a biological, will not going to last. So I need to just make it for this person. But also with the monoclonal antibodies, it is designed for someone rather than it is kind of generalized. So the new biologics also involve a lot of compounding because they are target therapy rather than it's a generalized one product fits all. Okay, but also based on how long the person will use this individual preparation. Manufacturer will not going to do for just one person. They need to have profit for producing larger batches. It is mostly done, as said, in hospitals and involve preparing parenteral nutrition solutions, cytotoxic drugs. Sometimes we do specific eye drops, especially for people with late AIDS or in HIV. They will require a specific eye drops, but also non-standard product like potassium chloride doses. Occasionally we do some antibiotics and analgesics, especially with the move from keeping people for long time in hospitals. We usually send the people home and give them their injectable antibiotics to continue at home parenterally, or their analgesia, example for patients diagnosed with cancer during the treatment, or if they move to palliative care.
But there's an important point here. Hannah's talked about some hospitals having compounding units, and now there being some manufacturers. A lot of this depends on geography. In a country like the United Kingdom, clean rooms are extremely expensive to operate. And where you've got good road networks and good transport infrastructure, quite often it is better to concentrate an industrial compounding unit in between a number of hospitals and be able to produce products quickly and ship them to the hospitals. This gives much better economics than having a separate compounding unit in every hospital. But there are some hospitals, particularly specialist teaching hospitals and so on, that need these sorts of facilities. And so in the UK and in your country, the compounding center at the Cipto Mangunkusumo Hospital in Jakarta is one of the world leading centers of pharmacy aseptic preparation. And we need in our best hospitals these facilities for the difficult patients.
Yeah. So let us go back to a bit of history lesson. This is really wasn't always there, this concept of aseptic products. It started because we seen the impact of producing products which their sterility in question. This happened in Germany in pediatric hospitals, where 11 babies died after receiving parenteral nutrition. And the investigation went to discover that the process where the products were put together, the antibiotics were put together, wasn't contained and contamination wasn't prevented. I mean, 11 babies with 11 families affected, it's a quite big deal. If you look around, you know, any death is drastic, but again, when it's a babies, it affects people more. Why? This is how it used to look like in a clean room. It used to be just in a corner of the pharmacy in a hospital, or in a corner of compounding pharmacy. The dress was just a face mask, yes, behind glass, but again, your air around you full of dust, the people walking, people moving, and as you can see, no gloves worn. So we start to think it must be something where we can do to reduce this contamination. Moving from there, part of the history. If you look, it's not unique to one country. Germany was just one case, alerted the world. But if you look at around the world, you've got in Australia, you've got in the USA, you've got here in the UK, Brazil, Malaysia, all around the world, there is incidents alerted the world to why we need to have new process where we can stop the contamination in products were done in a way where the environment wasn't contained. From there in 1976, the science come up with the air filtration methodology, and we started to use cabinets, and then we start see the code of good manufacturing practice coming into effect, and we start validate process, validate systems, validate people practice. And this was the trigger to where we are today, where people need to be covered from top to toes, from head to toes, no skin exposed, and operate in such a manner where they don't introduce any particles, any bacteria, any foreign bodies to a product they manipulate to be administered to someone vulnerable or someone diseased at the time, where they don't really need any additional impact to their health. You don't need to observe people while you're sitting behind them or next to them, and you will see the structure of the clean room shortly. Observation can be done external to the room, not inside the room. Supervisors and so on don't need to enter the clean room to see what you're doing. It's usually there is observation windows and hatches where things can be given or received inside the room, dispatched out of the room, but also people standing outside watching the process to make sure no one dancing, singing, or doing something or doing something you shouldn't be doing.
And as a general principle, the minimum number of people to successfully, satisfactorily do the job inside the clean room area, the contained area. This is again why supervision, supply, etc., is all done from outside of the cleanest zone.
Yeah. So if we think about picking the stock off the shelf, printing the labels, collecting the consumables I will need to use, all of this happen outside of the clean room. Only thing happen in a clean room is the manipulation, is the compounding itself. There is nothing called, I will leave the door half closed, so if anything happen, I can run out. It doesn't work this way. The process, the entry is different than the exit point. The people inside need to be dressed in such a way. The products entering the room need to be cleaned beforehand. And at the same time, the rubbish or the final product need to be removed in certain manner. But we will go over this in very detailed way in a few slides. Okay, globally, unless you have different ISO code, the ISO 14644.1 is the globally used one. Why? It's a kind of talk about everything from the construction of the clean room up to the person who doing the compounding, up to the final product quality, and the quality control during the process and the quality assurance at the end of the project or of the manufacturing. So it kind of covers the whole entire process. The most commonly used filter, we call it HEPA filter, and we'll talk about it in few slides to explain how it's actually structured. The air entering the room controlled, the amount of time that the air change in the room controlled, the amount of time the room in operation is controlled, the number of cleaning is controlled, the many times we test the environment is also controlled.
But there's also aspects like HEPA filters, which we'll talk about in more detail in a moment. But the people working, and particularly the people managing these areas, need to understand the technology.
Yeah.
Because a HEPA filter does not work from switch on.
Yes.
A HEPA filter improves in efficiency as it runs for a period of time. So it's really important to understand that most of these rooms need to be actually started up and run for a period or left running continuously 24/7 in order to be efficient.
Yeah. So if we're looking at the structure of the room, you've got, can you see the arrow? Yeah. So you've got this outside area here. This is your, the outdoor environment. This is where the building exists. And then you've got your pharmacy department, or where the clean room will be in. It's a building where you have your drugs, your label printers, your consumables, but also your change room. And then you've got the clean room itself, where it's contained, the environment controlled. And then you've got where you will go to manufacture your product, which it can be laminar flow cabinet or isolator. And as you can see, it's material entered from one place and exit from another, people entering from one place and exiting from another, but also the waste going from different direction where your good products, your final products will be exiting. So it is the whole operation controlled, where the main bubble, the one in the middle, where we called B and A, and we will go on the grades in a second, these are very contained and very controlled. Buildings will need to be tested before we even use them. Patrick was saying you run the room before you start your manufacturing, and this is absolutely true. Why? Because we want the room to be, during operation, equivalent to when it was at rest and as it was built. What this mean? When we build the room, we will test the air changes, the air filtration, while there is nothing in it. And this microbial count and particle count will be our guide to make sure that we maintain this when the room at rest, where after working hours, and when it's operation. So you will find these rooms, for example, cleaned at 5 o'clock in the morning, and then left to rest for maybe an hour or so, but then everything turned on, the room air filtration, the room ventilation, everything turned on at least an hour before, we say an hour to 20 minutes before the operation start, to make sure that again, we reached the quality of the air without people inside and with people inside, where it is the acceptable level of particles count, but the cleanliness and the quality of the air. How we measure this, I will show you in a couple of slides. So the air will have also one direction. It is not cyclone. If you look at room with air condition, we have kind of cyclone process. Why we want the nice cold air to be coming around us all the time. But this also promotes infection and contamination.
You have a question, Michelle?
Yeah, I will do in a second. Yeah. Where in a clean room, the air coming only from one direction and exiting from the bottom. So coming from the top to the bottom. Why? If it's coming the other way around, will contaminate my product. If it's going around, will contaminate my product. So the only way I keep things clean is the clean air coming over the product and going out. And me and everyone else in a room, coming and going out. Yes, Patrick.
So the question from Fabrian, you need definitely a person appointed to...
What's the question?
Sorry, the question is, do you have to have a quality assurance person in order to assure the facilities and so on?
Absolutely.
Yes,
yeah.
absolutely. There will always be a person who is designated as responsible for the management of all the records, all the testing records and so on, all the maintenance records of the facility.
But
now,
yeah,
there is also internationally the designated qualified person, QP, under general pharmaceutical manufacturing practice. Now, you do not necessarily have to have somebody who is a trained and certified QP. It depends on the country and the local legislation. You may not necessarily have a QP in charge of the facility, but you will have a QP who will have to sign off on the facility, having inspected it.
Okay, so if we go back to the previous slide, this one, as built, need to be signed off by qualified person. Qualified person who will certify the building as to be registered as a clean room. So the acceptance of as built must be done by qualified person. This one will be user quality assurance. This one will be user quality assurance. However, during the process, periodically, and in the UK, it's annual. In Australia, it's every 6 months. You will have a visit from these qualified people to come to recertify you or accept that you are complied with your certification. So someone will come to take air sample and fingerprints at rest and in operation. It depends on the country process, but definitely the building acceptance, when it's done, and the certification must be done by qualified person. When we say a user certification here, we're talking about someone who is trained to be able to do this job, not the lower dominator, not the person who will just enter the room to manipulate the product. You will have someone assigned as the quality controller and the quality assurance, and they are two different processes. Quality control, it's someone test the room and test the product at every step of the production. So to make sure the lapses being picked up during the process rather than at the end of the process. And this done, again, random done at random, but also done in frequency to ensure that the process not falling apart and people doing what they should be doing, and can be triggered when things go wrong to become more frequent. Quality assurance is a must, and it must be done every day on every product. Why? Because you look at the final product before you send it to the patient. So make sure you don't confuse these steps. So as built, need to be accepted and certified by regulatory body as possible to be used as a clean room, at rest and in operation certified by the user, trained user. Quality control done at every step on the process at random, but also the frequency triggered when things go wrong. Quality assurance done every day on every product before the product accepted to be injected into a person. All right. Not only the building controllers, but also we have what we call air locks, and the air locks will be used based on the product we are manipulating. So injectable aseptic is the highest grade. We really don't want, we want the air pressure to be in a way where nothing enter the room and everything kind of exit the room and the product is safe. So you can see it like the middle one, where cytotoxic products, we don't want anything from the product to come to us, so the pressure will be different. So we call it positive pressure and negative pressure. But also you want the airlock to be working on one direction. So which you mean away from the clean room rather than to the clean room. So I want the clean room air to be filtered in a way where it doesn't contaminate outside, but also I want the outside air to be going in different direction rather than entering the clean room. So again, we manipulate this based on what the room will be certified for. And you may find clean room certified for ionized products, certified for cytotoxic products, or certified for aseptic. Why? The location of the filters will also change. The pressure or the airlock in a room, style and direction will also be different. So the room need to be designed for what it will be used for. The change room is what we call the anti-room, and the clean room is the one we manufacture our product in. And as you can see, the pressure will be different from the anti-room to the outside world and from the anti-room to the aseptic room. And we also always control this pressure to prevent contamination.
In terms of keeping the product better safe, positive pressure is always the best. But as Hannah said, we use negative pressure for things like cytotoxic drugs, where you don't want droplets, vapors, etc., of cytotoxic materials being carried from the clean room out into the environment. So in that situation, you use negative pressure. It's not as good from the aseptic protection point of view, but it's protecting the environment from the product that you are preparing.
Can someone put the time for me? How much time left, please, in the chat? Thank you. Okay, so we say the sterile production is by design. So we need to make sure that the area we work on have surfaces can be cleaned and with low particles. I put a lot of videos in this presentation for you. You can watch later on when your academics share the slides with you later on. So if we look at the change room, again, it's designed with an airlock. When you have usually bench, you see it in one of the videos I have there. You usually have bench and then a sticky mat behind this bench. So you enter the room, you change your street outfit, and you put your sterile clothes up to the point where you're putting your boots on. When you put the first boot on, this leg need to be in a clean area behind the bench, and then you move your other foot with the clean boots into the clean area. So nothing of your street clothes need to or should pass the bench, which divide you and the lockers from the sticky mat, which is leading you to enter the clean room. Okay, you don't have to carry the product with you. The product will be given to you through a hatch while you are inside the room. So you will change and be ready, enter the room, and then you will receive the prescriptions inside. Entry to the processing area, we said, will be through an airlock. And at the same time, the air filtration will start at this point. It should be normally at a differential pressure between 10 to 15 Pascal, which means nothing you will carry with you. The air will stop you, its air curtain will stop anything, wash you, kind of shower you with this kind of strong air and pressure to eliminate anything been falling over your clothes or anything you're carrying with you. Okay, and for sure, you will have to follow a certain process. I think we covered this slide previously. So the clean room physical structure is controlled, particular matters are monitored, and keep your eyes and ears open because I will ask you questions. Microbiologically monitored, cleanup time and recovery time need to be maintained. During clean time, we produce a lot of particles. This is why we have to leave a gap between cleaning and the first time we will start work in a room. And this time we call it recovery period. Why? We want to return the room to the same quality when it was at rest, okay? And then filtration integrity maintained, temperature and relative humidity maintained, differential pressure differential maintained, and all the indicators, all the testing happen at all time.
The temperature and relative humidity is really important. Clean rooms, quite often people feel, particularly people from a warm climate like yours, feel the clean rooms are freezing cold. But this is because we need to control the risk of growing organisms like Legionella in the air conditioning ducts. You remember Legionella was discovered from contaminating air conditioning systems. Yeah. So our clean room environments control the temperature and humidity to prevent microbial growth within the air ducts.
Yeah, and this last point here is the warning systems. You will find warning system for everything, for high temperature, lower temperature, humidity, particles, still air. You will find that the room equipped with alarm system to warn them, the person in a room that they must stop compounding and the room need to be shut down or cleaned. All right. So the grades, if we look at the grades of the room, so we've got our main grade is the grade A, which the area inside the laminar flow cabinet or inside the isolator. The area which it has to be 100% clean and based on the count approved, particle free, and need to be microbial free. So grade AA, there is no kind of concession on the environment inside this area, this inside your cabinet. It must comply. Same with grade B. Now, grade B these days exist in clean rooms where we're using laminar flow cabinets with isolators. The B zone become equivalent to the C zone. Why? Because the isolator is enclosed system and we don't need to do the same restriction we do when we have cabinet flow, laminar flow cabinet, because it's open to the B zone, where the isolator close to the B zone. Grade C and D, they are, grade C is the area where you will change your outfit, but also you will finalize the final clean for your product before it enter the grade B zone. Okay. The HEPA filter, usually in grade B and in grade A, where the air changes and air filtration in a lower grade of HEPA can be in other areas, but very unlikely because of the expense and the requirement for maintenance. So usually the tight filtration are in B and A rather than in C and D. Yeah. Yes.
So the other question, thank you for the answer, but more questions if you don't mind.
Yes.
Are there any limitations for the dosage form that can be compounded
Absolutely.
using the aseptic facilities?
Yes.
And do we still have to perform media fill qualification?
Yes.
Just like the manufacturer for doing aseptic production facilities?
Absolutely. I have this in the last 10 slides. When we manufacture products, you're allowed only to manufacture one dose at the time, even if it's for the same patients. So if someone will have medication every 8 hours, you are allowed to compound one dose and send it out, and then do the second dose and send it out, and the third dose, and so on. You're not allowed to do the 3 doses concurrent. So one product manipulation at one time. Now the clean room must go at rest in a very frequent shifts, you can say. The shift doesn't go over a maximum of 3 hours, and then you have the at rest period, which can be between 20 to 1 hour with the room is empty and left for running for the air to be reduced down again to the same quality of at rest. So yes, the room work on shifts. The manufacturing go for certain number of products, one product at the time. Every person can work for 8 hours or 12 hours, but they must have break every time the room put at rest. So it can be every 2 hours or every 3 hours. So the amount of products you produce during the 2 or 3 hours they're not limited, because one product may take 5 minutes, the next may take half an hour, the next may take an hour. So the number of products is not limited, but the number of doses you're preparing at one time is limited to 1. The length of the shift is limited by maximum of 3 hours. I believe most rooms will run in 2 hours shifts, but when it is a busy hospital like here in the UK, or in some hospitals in Australia, we may extend it. In Canberra, for example, our shift was about 3 hours, 2.5 to 3 hours. And when we're not busy, we used to reduce it to 2 hours and then 20 to an hour at rest break. So it depends. Did I answer all segments of the questions? Or?
I think so. So, but
Okay.
yes, part of the validation of the facility and the operators is doing media fill tests and so on. So
I have it at the last.
Yeah,
in
so
the
we'll
person.
come back to that.
Yeah. Air changes, minimum of 20 air changes per hour. So you remember the diagram I had at the beginning, where the air coming from the top, going to the from the ventilation. This need to happen 20 times in each hour. Okay, so up to 20 times. And it continued to flow as such. We mentioned the HEPA filter at the beginning. It's a high efficiency particulate air. It is basically very, very long sheet of very fine pore papers, where they are folded in a certain way, where the air must go through the whole lot before it go out, and then kind of packed in column with metal screen. And this is why in cleaning, we shouldn't be spraying this with alcohol. We should be spraying the particle or lint-free towels with alcohol and then cleaning the metal screen. If you're spraying it, you wet the paper, you wet the filter, and it may not operate to maximum capacity. So the filter need to integrity need to remain intact. These filters need to be checked periodically based on the acceptance of the room. So it will be said you have to clean the filter or replace the filter every certain amount of times a day, years. So this will be in account of the quality assurance certification of the facility.
But also part of the efficiency of a HEPA filter is an electrostatic charge from the airflow.
Yeah.
And this is why the efficiency improves after a period of running.
Yeah.
So generally speaking, most HEPA filters only achieve full efficiency after running for at least an hour.
Yeah. So if you think a septic product and the cabinet right here in front of me, my HEPA filter will be in front of me. Why? Because it needs to be clear the air coming from zone B and from me to protect my product. Okay. If I'm in cytotoxic or ionized room, my HEPA filter will be on the top above the product. Why? Because it needs to take out any fumes or particles coming out of the product away from me to protect me. So the location of the HEPA filter will be important. If you think about a box, okay, the side of the box in front of me will have a HEPA filter. If I'm doing a septic, it will be on the top of me if I'm doing ionized or cytotoxic. I am the one need to be protected when I'm preparing cytotoxic or ionized. My product need to be protected from me if I'm producing a septic. Okay, so the location important, and I will show you the design at the end.
So again, forward displacement is the best. Downward displacement is less efficient for the product, but vital to protect the operator if the product is cytotoxic or ionizing radiation.
Yep, and this is how the cabinet look like. The HEPA filter in the back when I'm doing aseptic, and I manipulate the product inside. And this cabinet will be called zone or grade A. This room where the person is standing will be called grade B or zone B. And as you can see, the air coming from top, going down, wash everything in a way to get out of the room.
And there will be extraction ducts either at floor level or at the bottom of the walls.
Yeah.
So that the air goes out through a different route.
Yeah. And the main idea is to clear any airborne particles or things should not be in the room. So airborne particles need to be limited. Airflow pattern need to be known and controlled. Temperature and humidity controlled, air pressure regulated, special construction and material, but operating procedures also need to be regulated.
And it's a bit like a pilot before they take an aircraft away. There will be a control panel, and the person managing the unit will go and look at that panel before any shift starts, and look at those gauges and actually log where those gauges are, because even if the gauges are in range, you may see trends that warn you something is about to go wrong. So, and then also these control panels are also fitted with alarms. So if pressures and so on go outside certain ranges, an alarm will sound and work should stop until the room is sorted out.
Yeah. So if I'm looking at my compounding process, how it will happen. So this is the pharmacy. I selected everything off the shelf, and then I had the first dusting, cleaning. I put it in a tray, and then the tray itself is cleaned. I send it to the area C. The area C will replace this tray with a tray coming from a sterilizer, and then will clean all my products with lint-free towel and alcohol. All the packages are cleaned from outside by actually cleaning, not just spraying. I need to remove any spores. But then the label printed, the dose rechecked, and then the labels itself cleaned and put in a plastic zip bag, and then everything put in a totally sterile tray. And this tray put in a shaft on the side of the room, no one touching it anymore, to the zone B, where the operator will again clean everything before they use, conduct the manipulation, and then from another shaft, send the product out. Isolator is different. So in a clean room, allowed only with maximum of 3 people in a room, only 3 people. So a 3 laminar flow cabinet maximum in a room. Isolators, you may have 6 isolators in a room. So you can increase the capacity rather than change the environment. Why? Because as you can see, the isolator, even the shaft coming out, all close the system. So is this what I'm saying? The entry shaft, this is from area C. Your non-compounded elements will be put here. You manipulate in an isolator, and this shaft here is the exit. You're sending the product out for the final quality assurance, and then it will go to the patient. Okay, we said about this one, and we spoke about this one as well. This is just to show you how much the particle size increase by very, very simple movement. This is why we say our movement inside the room need to be very controlled. And I don't know if you can see me, I will just have to stand up. So when we're standing in the room, we either sitting in a stool and not moving, or if we are standing, we basically moving like this, taking things from the main container, manipulate it in front of us, and then put the rubbish in a rubbish container or send the final product out. So as you can see, I'm moving from elbow in, out, middle, but that's it. And this is why the shift usually very short, because you're very still inside the room. Any additional unnecessarily movement, again, will worsen the environment inside the room, including shouting and talking. Just to show you the particles, and at the start, this at rest, at the start of the shift increase, but as you can see towards the end of the shift, it is higher. And then you go at rest again in a cleaning time, it is the highest. This is why we need the recovery time before we start the shift.
The cleaning obviously involves reaching up on wiping walls, wiping high surfaces and so on, a lot of movement. So this again reflects the difference in the amount of movement that people are doing. And of course, the rubbing and so on of cleaning operations, again, also sheds a certain amount of particle off the surfaces, etc.
Yeah. So clothing wise, again, a straight clothes should be kind of controlled. The hair, beard, mustache need to be covered, starting from the area D, because I don't want to drop anything on my product, but I don't have to wear the sterile suit I'm wearing to the inside. You can wear scrubs like the one doctors and nurses wearing, but the hair definitely need to be covered. Grade C, we're going to a little bit more concise. So we're using the lint-free towels and clothing to make sure that we're not shedding anything on the containers. We're going to send it to the area B, where area B, basically nothing of you showing, only your lint-free material. You're wearing the coverall. We have to use coverall. We don't use gowns anymore. We have to use coverall, and then your head to toes covered, including safety goggles to cover your eyes. So nothing of you as a person actually exposed or can produce anything into the product. Okay. All surfaces also need to be from the same kind of material. I'm going through the slides faster because I think I will run out of time. I thought I have 2 hours and not one. Sorry?
1.5.
Yeah, but I thought I have 2 hours. Yeah, so we need to, the material you will use, again, it depends on the budget of the facility. Sometimes you can have reusable coveralls, which mean if you're working 12 hours, you can use it for your first shift, second shift, and third shift. So it's reusable and then disposed of. Or you can use coveralls where it can be laundering, which can be sent to the laundry to wash and sterilize, and then you can use it for next shift. It depends on the budget. Most facilities will use the blue coveralls, which they are from kind of plastic material. but
ceramic kaolin is the
yeah,
actual material.
it can be washed and reused. So it can be reused during the day, but reused again for another person in the next day, in the next shift, but after it's been cleaned. Why we're using coverall? It's very important. The research is telling us we shed material from our guts more than anything else. So we need to close the area where we can shed. So it's basically the perennial fallout is what we need to control. This is why we're using coveralls these days rather than the gowns we used to use in all the days, okay? So it is for very good reason. And also the boots, you will see the coveralls, you almost packed like this. So even the legs of the coverall need to be inside the boots. So we basically preventing any fallout from our bodies. And even here on the eyes, it's covered by goggles, safety goggles at the end. So nothing of your human body can contaminate the product as such. Okay, if you work in isolator, you may be able, it depends on the type of the isolator. If it's the state-of-the-art technology, you may be able to work in your scrubs, but it depends on how the room is certified for. This is what I call scrubs. It's not the street dress. It's what doctors and nurses use in operating theater, you can say. Okay, how we test the air? We test the air by media. So we have plates in the corners of the room to determine if there is a fallout of bacterial contamination. But also you have some inside the cabinet itself. And we will also test you when you put your first set of gloves, and then when you put the second set of gloves. During operation, you will also have to do this. So if your shift is 2 hours, your process might be you do your fingers every 30 minutes. So you will do it at the beginning, and so 4 plates will go out of your shift to test if you're cleaning your hands in between, and or if you're touching yourself or you're touching the things you shouldn't be touching in the middle. So we will use the agar plates, culture plates, to make sure that it's a process, during the process, your hands remain clean. The cabinets itself, which we can test the cabinet and put inoculate the plate, or the floor is also clean. But agar dishes also used in more innovative ways than just the plate itself. I will show you the guns we use in a few minutes. So everything, the floor, yourself, the cabinet need to be cultured during the day. And why? If anything went wrong, we go to this data for that day, and we can know what the contamination happened. But also if the contamination happened when certain person in a room, again, we can detect that this person not doing what they should be doing. So they are very important picture of how accurate the process is, how accurate the system is, and the facility.
And trend monitoring is an absolutely essential part of looking at clean room operations, because oh so often when something goes wrong, if you look back at the data very carefully, you can see an emerging picture that actually was suggesting that there was an issue developing. And you learn that for the future. If you see that pattern arising again, you deal with it prospectively, not after you've had an incident.
Yeah, and it's usually done as zero growth inside the cabinet, but you will find allowable number of colonies in the room, at the floor, close to the doors. Every zone in the room will have allowable count of colonies, where the only area it has to show zero at all time will be inside the cabinet. And for sure out of your fingers. Okay, and I will show you what we use in the room. So instead of the dishes exposed and you're doing manually, you've got equipment like this on the corners of the cabinets in the top, where the agar dish actually here inside, and the air flow going over the calculator or the machine all the time, and then the plates drop down and another plate come up every frequent time. So you produce all your plates on a go, rather than someone has to come inside and actually change them plate by plate. But your fingers will have to be done during the process, and before, at the beginning, and at the end of the process. And when you wear the first glove, when you wear the second, your sterile glove. We need to have this data just in case someone have reaction to product you prepared. We need to go back to the microbial data to know if you caused them to experience anything introduced from you. But we're also talking about particles. Again, inside the cabinet, you will have particles calculator or counter, and this will alarm if the particle inside the cabinet increased. This is why we're telling people, if you want to do your job and you don't want to be interrupted and basically sacked or prevented from working in a clean room, you need to control your movement inside the cabinet. The more you move, the more particles will be introduced, the more times the alarm will go off. And every time the alarm go off, the whole room will be shut down for a period of time to rest before you can commence work. So again, the alarm will tell us the story of how graceful or you move a lot inside the room, inside the cabinet. So 2 alarms, 1 in a cabinet and 1 outside. And if it's a closed system, you may have the particle calculator also in the closed system with and giving you reading, frequent reading. Okay, and we calculate particles by meter, cubic meter of air rather than just the airflow. Okay. And I think we covered this one, and we covered this one as well. And we spoke about temperature and humidity. Yes, we are intentionally need to use lower temperature. So between 20 to 23, maximum 25. It's uncomfortable for the operator, but it is less prone for bacteria to grow. The higher the humidity, the perfect weather for bacteria to grow. So again, we need to reduce the humidity. So if you imagine it's cold and dry, so this is why the shift is very short. You need to rest, the room need to rest for you to be able to effectively concentrate and work in the next shift. Again, the operator is very important. So some people will be asked to go and improve their personal health, or not to be in the room during certain period of their life if they have infection, or if they have acne or cold sores or dandruff. Why? The fall of this condition will be greater, but also if you are unwell, you are not allowed to be in a room. So if you have viral bacterial infection, you're coughing, you're sneezing, you're not going to be allowed in a room. Long nails, jewelry, also not allowed in a room. Everything needs to be taken off before you enter the room. Your glasses allowed because you can clean them, but also you will find that if you work in a clean room and you wear glasses, I will bring mine to show you in a second. It's in a drawer, Patrick, if you can bring it in a top drawer. I will show you my goggles. If you're wearing glasses, they will make you a goggles you can wear in a clean room with your prescription. So you don't have to be uncomfortable with double glasses. Yes. No, it's another container. I will show it to you when Patrick finds it. It's a larger case. Okay, so but at the same time, if I show you the pictures where we were taking the agar, you're not allowed in a room with this kind of gloves. You need to have tight gloves, tight enough to give you the perfect grip. So isolator gloves, even isolator gloves, never mind, Patrick, I will find it later. It's a small case. You need to make sure that the isolator gloves also is designed for you, which you mean will have, sorry, Patrick, I think I found it. I found it here, Patrick, it's okay. So this is my aseptic goggles. It's my prescription glasses, but in safety goggles. So I don't have to wear two on the top of each other, which can be quite uncomfortable during your work in a room. Okay, and the gloves, the isolators, if you're working in this shift, they will put gloves to your size so you can have better grip when you manipulate your products. Okay. Gloves, we always double glove, and the inner layer of the glove will match the product I'm preparing. It can be any color. If it's aseptic, it needs to be purple. If I'm doing cytotoxic, it needs to be yellow. If I'm doing ionized. Why? Because it's a good indication when I'm finished with them to know what product I was doing. So the person doing the cleaning of the room need to know where this was to go. If the glove showing yellow will go ionized, purple will go cytotoxic, otherwise will go in a normal biological waste. Okay, so it's very important. And we spoke about the goggles, the eye protection. Posture, as I demonstrated to you, the lowest possible movement, and it's only arm movement. You don't need more than that. And I think we spoke about this, but just to make sure, singing, talking loud, chatting, last thing will be allowed in a room. I've got enough. Now the product, yes, please, I'm sorry. The product you will use, we say it's lint-free. So this kind of tissues, you will not be allowed to use it. Excuse me, give me a second. Okay, so everything need to be wiped rather than sprayed, and wiped with material does not lend any fiber into the product itself. Yeah. Okay. How much left for me? Okay, so I will just go over the slides very quick. So again, sterilization. We use indicators like this. We can use filters to improve the sterility of products, or filter needles to prevent the glass from entering my product. We need to validate the process and validate your ability to deliver the process. And the question we had at the beginning about the broth, yes, you will need to, and you will do this as operator at least every 6 months. Which means we will give you...
You can take a drink first.
It's okay. It's because of the time.
Okay. It's 5 minutes left.
Thank you. Thank you.
Okay.
So you will have to be validated every 6 months, which means instead of saline, we will give you broth, and we will ask you to add things to it as if you're doing any prescription. And this will be incubated, and we will calculate the bacterial growth in it, which will tell us if your process caused contamination of the final product or not. So every operator needs to be validated every 6 months or so. Again, it depends on the organization procedures. I mentioned the filter needles. We need to, if we breaking ampoules, we can't just draw the fluids out of it. We need to use certain needle with filtration system in it to make sure that we're not taking any of these little fibers produced or particles produced when we broke the ampoules. So we need to filtrate the fluids before we add it to our product. Okay, and this is just another case study to tell you it's you guys as pharmacists are the best person to do the process. We proved to have less contamination when we do our process than when nurses do it or when doctors do it. So we need to keep our standards to keep this good reputation going. And it's in your hand as a new generation. Okay. Vials. The cleaning of the vials very important, and you need to make sure this plastic cap removed and cleaned underneath before you start to draw any thing out of it, and cleaned especially around the metal cap, because spores usually hide there. Okay, so the main part you only can use is this little dent in the rubber cap of the vials itself. final product, yes, you need to inspect in the light to check if there is any floaties, change in the color, any precipitate before you send it out for the patient to use. I just mentioned the laminar flow cabinet, and this is my last few, 3 slides. As I said, the filter location, it depends on the product, in the back or on the top. The structure of how you work. I've done this when I was working in Australia. So your working zone, if the filter here at the end, so this is your working zone. The area here is the dirtiest one. This is the cleanest, which close to your filter. So anything open, any final products need to sit here because it's near the filter. The best area to be, this is your working zone, and this is close to your body. For aseptic, however, if we're talking about cytotoxic, it will be different, and you mainly, your working zone will be in the middle because your filter on the top of you, and this is where you will be working. Okay, and I think I finished this part, so I will escape this one, and I will share another screen with you. Hopefully I have allowed to use another 10 minutes, because you need to answer as much questions correct as you can. And then at the end, we will ask you how many correct questions you have, and you may win a prize at the end. Susie, do you want to say anything before I start?
Maybe you can start now.
Okay, so I can see, Patrick can see my screen, so I will stop sharing and I will start sharing again to select the correct screen. Okay, so the way you do it is you will go into, you type this in your phone, polleverywhere.com, and this number, and then you can start answer the questions. And we all see it on the screen in front of us. I will give you 30 seconds or 1 minute maximum for each question.
Baik, untuk para partisipan mungkin bisa langsung menuju ke link yang telah diberikan oleh Dr. Hana. Lalu nanti akan diberikan waktu selama 30 detik sampai 1 menit untuk menjawab tiap pertanyaannya. Dan nanti bisa dicatat ada beberapa pertanyaan yang dijawab dengan benar dan bisa diberitahukan kepada Dr. Hana. Terima kasih.
Okay, we move to the next question, but I will show you the correct answer first. Okay. Sorry. Yeah. Okay, so here is the correct answer. Well done. So next question. Fantastic. Okay. And 91% of you got it correct. Well done. Next. Remember the question not asking you for particles, ask you for microbial cells. Remember the picture? Think again. 70% of you need to think again. You all, except of one person, need to think again. Why we wearing coveralls? Why we wearing coveralls? Where's the intestinal tract end, guys? Okay, so make sure you understand the concept. So only 9% of you were correct for this question. Okay? Okay, 15% now. Let us move to the next question. Okay, we're nearly there. Got only a few more questions to go. Okay, I'll give you only 30 seconds for this because it's an easy one. Okay, well done. Okay. Time is over. Only 9% of you correct. Okay. I do understand it's a quick talk, and I didn't expect you to know everything from just 1 hour. But at the end of the day, will have to be one winner. Think again. Yeah, beautiful. Now we start to see correct answers coming. Don't doubt yourself. People who have the last option on the screen need to think again. Okay. Well done for many of you. It's all the statements are correct. Everything needs to be controlled. Okay, the question asking you where you compound your final product, in which area we compound the product. All of you need to think again, except only few number of you. Remember where I do my final product, where I'm standing, compounding my final product, which will enter the person body. Where you manipulate your product. It will have to be in a cabinet, isn't it? And where's the cabinet? Is the cabinet in D, C, B, or A? So only 21% of you is correct. You need A and B. Yes. I think I will skip this question because it will be a bit difficult for you, but well done. I will just give you the correct answer. It's the 6 minutes. And this is the very final question. So what we used to wear. Okay, I think we'll stop here. It's a woven or non-woven, as long as it does not lint. It's laminated and does not lint fiber. Thank you very much for having me, guys. And I think the last thing after I stop sharing the screen, I will ask you with full honesty, tell me how many, if the person had 10 out of 10, 9 out of 10, or 8 out of 10, so you can win a prize. But I will leave this for Susie to decide. Okay. But also thank you so much for asking questions.
Okay. Thank you, Dr. Hannah. You have given us a lot of interesting and insightful information. And also thank you for the quiz. It was a fun way to help us to remember the material. And we hope all of the participants are satisfied. Okay, so moving right along, we will have the Q&A session. For the participant who has question, you can ask directly via Recent Feature or indirectly via chat room. Anyone who has question, please? Okay. There is Mbak Binti, Sofiatul Nadira. Maybe you can ask directly to Dr. Hannah and Professor Patrick.
Okay, thank you, Gita Laila. Okay, okay. Hello, Miss Hannah and Professor Patrick Ball. I am Binti Sofiatul Nadira from third year pharmacy in UII. Okay, I would like to confirm in advance that for handling sterile preparation, it is important to always provide special treatment, right? This is used for product protection from microorganism contamination, protection of personnel and the environment against exposure, stability of preparation, as well as the image. Therefore, to avoid things that are not desirable, the handling of preparation must be carried out in a special sterile room in a disciplined, careful manner, and requires adequate knowledge and skills to prevent unwanted risks. Okay, for my question, or I want to some question for Dr. Hannah Morrissey. What is the specific role as a pharmacist in a hospital to handle sterile preparation? And how do we quality control sterile preparation in hospital?
Yes,
that's all for
okay.
me. Thank you.
So you're welcome. Your role is from beginning to end. So the doctor role will end by writing the prescription. Your role will start from reviewing this prescription to make sure that it is correct in dosing and so on, calculate the amount of fluids you will draw, and make sure to use the correct volume bag to add the drugs into it. Make sure the product and consumables required to manipulate or compound this product are correctly and cleaned. And then you do the compounding and you do your quality control on the process. You do the quality assurance on the process and in your final product. And then when the product leaves the room, another pharmacist will do another quality assurance check to make sure that the product you produced is correct to go to the patient and put the storage requirements, use by date, and so on. At this point, the nurses will take over from you to administer to the patient. Yeah.
As well. The problem from RIFA, the problems with compounding sterile preparation during the pandemic, in terms of the clean room, very little, because the clean room will contain that sort of contamination. The problem is with the staff, because you must observe the rules
Yeah.
of not having people with active infections and active sneezing and so on in the clean room environment.
Yeah.
And this put a lot of pressure during the pandemic.
Yeah. However,
the well staff.
yeah. However, during the period, the clean room use increased.
Absolutely.
Massively increased because we were testing monoclonal antibodies and antivirals to see what can work. And people were in induced coma. So eventually, for very vulnerable patients. So as a matter of fact, the workload was massive for pharmacists during the pandemic. I'm sorry, I interrupted you. Do you want to add anything? Yeah, it's like your role in the pandemic times 100. You are as important as anyone else who actually in the ICU. I hope I answered your question and answered Rifa's questions for Nadia and Rifa.
Okay, thank you, Dr. Hana and Professor Ball. Maybe another question from other participants. You can, okay, there is Andika, please. You can ask the question.
Okay, good afternoon, Dr. Hana and Professor Patrick Ball. Because I'm in Yogyakarta, let me introduce myself. My name is Andika Wahyuwardana. Let me ask question. What are the proper steps in dealing with errors in pharmaceutical compounding, and what things to pay attention if there is an error in compounding? Thank you.
Okay, so when we do compounding in a clean room, we always ask the operator, if you're drawing 10 ml by syringe to add it, straight away after you add it to your product, you still draw the syringe back to 10 empty, okay, and leave it in a tray. So when it gets checked outside, people know exactly the volume you checked. But remember also, I said there is glass windows in a room where an observer will be there all the time, observing what people doing to make sure that the process followed. No one dropped anything on the floor and picked it up. But it is the system you work through will eliminate the error.
But also, it is like any other sort of error monitoring.
Yeah.
When errors occur, you must record them. You must record who was involved, what the circumstances were, how long they've been working, etc. Because you do a periodic review. And if you can see trends emerging as to Hello?
Yeah.
We're back.
Yeah.
So you look for problems and you look for identifiable trends to see if you can plan in the future. So for example, if you have periods of very heavy workload where you then find errors are starting to increase, then you must plan to perhaps spread the workload out a bit more or bring in extra facilities or extra shifts to spread the work. So it's the same process really as any other error monitoring.
Yeah.
Don't just say an error occurred and blame the person. You must look for the root cause analysis of the error and try to find ways of designing your system for the future so that that error cannot occur again.
And this is why you're keeping record of plates and so on. to monitor each individual, and you validate each individual every 6 months to see that they're still doing the process. But also, if you look at the whole manufacturing process for aseptic, you have at least 3 people involved. The person outside the clean room on the entry, who looking at the prescription, inside the room doing the preparation and reviewing again this calculation of volumes and appropriateness. And then the person who will get the product from you out of the room before they give it to the patient, who will look at all the empty drawn syringes and empty vials and so on, to make sure that you use the correct products and the correct volume to produce your product. So you have 3 governance steps.
Do simple checks like weighing the finished product. So if you're making similar dosage forms and so on, if you've got a record of what it should weigh, if suddenly you get one that weighs something different, you know straight away there's probably an error been made.
Yeah, yeah. So we hope we answered answer your question.
Okay. Thank you very much, Dr. Hannah and Professor Patrick. Maybe we do have question more from other participants. You can ask by raise hand or chat via chat box. Okay, so we have the question from Dia Nur Hasana. What reference is commonly used in determining the beyond use date of sterile compounding products? And do you have any other recommended books? Okay.
Okay. So,
answer it.
So yes, there is some books you can use. However, this will be university academic study, where if we look at any clean room will have their own procedures, and their own procedures will be very well structured and step by step. You can't deviate from it. So process-wise, as a compounding, yes, you will use the pharmacopoeia, whatever pharmacopoeia is allowed in your country. But at the end of the day, I will say, make sure you follow the process in the organization rather than external copy. Every facility will also have a quick checklist. So it will tell you, for example, a liter bag, you allowed only for 150 ml extra to add to it. 100 ml bag, you allowed only for 15 ml. So certain things, you will have quick checklist to give you a guide about what to add to what. But also there is a injectable compatibility. Unfortunately, the book I have at work, not here at home. It's an Australian handbook. It tells you which drug compatible to what intravenous fluids. So you can't use, for example, sodium chloride for everything. The
question was beyond date use.
Beyond date use, you don't really have long expiry date either. You will either have maximum of 1 day, and the exception will be only for products people administering at home, where some of them might go for up to 72 hours because you usually don't use preservative.
And sometimes emergency situations can arise.
Not
but in terms of then, if you've got a product that's gone past, normally throw it away and make a new one.
Yeah.
But if you have an emergency situation, the other thing is plain common sense.
If it's eye drops or cream.
Yeah. but
Yeah.
look at the product. If it's still crystal clear, clean, no obvious change, then it may be okay to use it. But straight away, if something has changed about the product's appearance, it has become cloudy, it has changed color, you know straight away, out of the question.
But you become the only liable person of administering that. So if things went wrong, you are the only one legally liable. So the rule of the thumb is always someone will be on call.
Yeah.
If any emergency required, always someone will be there to prepare a product. And the main thing is if it's eye drops or topical preparation, you may, however, I will say 100% really, if I'm you, I will never use anything manipulated in a clean room for vulnerable patients beyond the determined expiry date. And the determined expiry date will differ. So for example, for analgesia, for antibiotics, you will see that they can be manufactured for up to 72 hours. For TPNs, also can be manufactured for up to 72 hours because we mix them only before administration. But for a daily dose, for anything used in a daily dose or multiple times during the day, I wouldn't go above the 24 hours allowable expiry date. It will be the rules of the organization rather than me sitting or Patrick sitting here telling you a blanket must do. Okay.
Okay. Thank you very much, Dr. Hannah and Professor Ball. Maybe I will ask my question. Okay, so the instrument for compounding and dispensing sterile products in Indonesia is quite left behind from other countries. So in your opinion, what we must do to minimize the error in compounding sterile products while the instrument is not as advanced as others? What is your opinion? Thank you.
I think it's an unfair statement. Okay, why I'm saying this? We visited Lina was? Rina.
Dr. Rina Mutiara.
Yeah.
At Chiptamanga Kusuma Hospital.
We visited her suite and they're beautiful. They do really very good job. It might be only one center or very few centers around the country, but your process, your work is very good and robust. I think what you are missing is the high cost tech closed systems, which doesn't involve people intervention in all the steps. Some steps are done by robots and some done by human, but also it's not available here in all suites either, or in America in all suites. It has to be an organization who got a lot of money to throw around to be able to use this very high technology systems. So if you control the people, if you use the proper standard clean room, you will achieve the aseptic product in affordable cost. The clean rooms are expensive regardless, but you can go from $500,000 expense a year to 30 or $500 million expense a year. So you need to have this money to be able to do that. And I think it is counterfeit products are the one you need to target. So counterfeit products, especially in consumables and in drugs, are the one causing the risk of starting by non-sterile product. And this what will cascade to producing non-aseptic product. So if the consumable saying it's a gamma radiated and put expiry date on it in 5 years, and the manufacturer took short cut and didn't gamma radiate it to sterilize it, it's a risk, correct? If the antibiotic is counterfeit and it doesn't have the same amount of antibiotic in it, so you will produce product that will not cure the patient, and you may be questioned as you didn't put enough antibiotic in it. So look at the raw material starting product, because the quality assurance in the small manufacturers are lower than the quality assurance in high manufacturing area. And I think this main area you need to keep eyes on, the starting products, the raw material and the consumables. Do you want to add anything, Patrick?
Only to say, ultimately, even the best clean room facility in the world only improves your chances of maintaining standards, because the crucial thing is the human factor. If human beings do the aseptic manipulations properly and reliably, you can even in emergency situations, and for example, there was a Dr. Ramanujam, who was a Malaysian doctor working in Chennai in India, actually validated an intravenous nutrition service where they were making aseptic products in a side room using operating theatre cloths as their sterile surfaces, but they rigorously validated their process. And it was the best they could do in the environment at the time. And he wrote a book about it. But what we all need to do as a profession is campaign to try and get appropriate facilities. Now, you do not need a clean room in every single hospital. And in actual fact, it probably means that if you do, you have the rooms underutilized and suboptimal skills with the operators. But you do need a certain number of centers geographically across the whole of your country,
accessible,
to be able to provide service where it is needed.
Okay, thank you very much for the answer from Dr. Hannah and Professor Patrick. So because we almost running out of time, I will open the question for the last question, maybe from the participant who wants to ask the question.
Sorry, we went over time. I know.
No, it's okay. It's okay. Okay, from Talita Luna, maybe you can ask directly to Professor Patrick and Dr. Hannah.
Professor Patrick and Dr. Hannah. Let me introduce myself. My name is Talita Luna Ramadisa from UII. So my question is, how do we do the aseptic dispensing to avoid the contamination of heat-resistant bacteria? Thank you.
How you do it to avoid contamination?
What was the particular thing you said?
Bacteria.
Of bacteria. Okay, and this will be basically the entire. You remember we said the plates, the entire testing of the room and the person and the cabinet. So it need to be zero at rest and need to be within the acceptable level during manipulation. but the person need to be covered head to toes, basically.
Yeah. And the quality assurance is achieved by not letting operators do the aseptic manipulations until they have been trained and validated. So they actually must be all the people working in the clean room producing product must have gone through formal training and done broth validation before they start making real products for real people. If you have validated facilities and validated people, that is how you produce clean products.
I think I understand your question now after I stopped talking. You cannot test it for bacteria contamination or bacterial contamination before you give it to the patient. Otherwise, there is no product to give to the patient. But keeping records during the manufacturing, plus any clinical symptoms the person will display, will be able to guide you if bacterial contamination occurred during the preparation or the administration or not. And if you know what it is, it would be easy to treat, but you can't test it at the end.
Well, but what you can do as part of ongoing monitoring, we run a system at the Birmingham Children's Hospital when I was doing aseptic compounding there. All the parenteral nutrition we prepared, after it was taken down from a patient, was just capped at the ward and sent to the microbiology lab. Now, if you find no contamination, that tells you you've got no contamination. If you find contamination, it doesn't tell you whether it occurred at the compounding step or at the administration step, or more likely at the administration step. But certainly you can do periods of monitoring like that as part of your overall validation processes. Now, but as I say, it only really tells you anything if all the products come back sterile. If all the products, or if some of the products come back contaminated, you've then got a lot of further investigation to try and work out where the contamination occurred.
And it will have to be always after the event.
Yeah.
You can't do it before administration.
You can't do it
yeah.
Okay, thank you for the answer, Professor Patrick and Dr. Hannah. We can see the enthusiasm of the audience is very great, but unfortunately, it's almost 5:30 p.m. So it means that our discussion session is over. So, ladies and gentlemen, we finally come to the end of this webinar session. Before I close the session, I would like to take the conclusion from what the speaker has presented. So compounding is one of the most important abilities that pharmacists should have. And one of the preparation that needs to be monitored carefully is sterile preparation, because there are so many contaminants that can soil the preparation, such as particles, sterogens, non-viable contamination, and also from human skin or hair. And then there are several ways to compound sterile products. One of it is aseptic processing, including aseptic dispensing, and then production, including the design. And to minimize the error on compounding, the main thing we must watch is the environment, and to make sure to follow the rules from the responsible organization in compounding sterile preparation. Okay. So next session is the virtual certificate submission. I invite the head of Master Program of Pharmacy, Apotheker Suci Hanifa, to give the certificate to Dr. Hannah and Professor Patrick. Mrs. Suci, please.
Thank you, Mbak Gita. Good morning, Dr. Hannah and Professor Paul. How are you? Nice to meet you again. Admin?
Nice to see you again. Sorry, I was muted.
Yeah. Bisa di-share sertifikatnya?
Okay, on behalf of Department of Pharmacy, we would like to extend our sincere gratitude for Dr. Hannah Morisi, also Professor Bol, for really impressive lecture.
Thank you.
And please accept this certificate with our sincere thanks.
Thank you very much. Thank you for having us.
Yeah. You're welcome. You both our idol, Professor couple, I think. Thank you so much.
Thank you. We will leave you guys to finish the end of the day. Thank you very much. It's always lovely to see all of you, and thank you for talking to us by messages or by unmuting your microphone.
And thank you for the invitation.
Thank you.
Okay, thank you, Mrs. Suchi. And in the end of this webinar session, I'd like to thank the speaker, Dr. Hannah and Professor Bol, for the informative and interesting presentation. And also thank you to all the participants for all the enthusiasm. I apologize for my mistakes in accompanying this webinar session. Thank you very much for your attention. I wish you all a pleasant day and happy fasting. I'm Gita Laila Rahmayanti. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam.
Thank you very much, Hannah, and see you, inshallah.
Thank you very much, Safidin. It's great to see you. I will see you later. Hello. It's so nice to see you guys.
Yeah, thank you.
Yeah,
we look forward to have you here in Jakarta in June, hopefully.
Yes. Yeah, we will try our very best. Very likely we will be able to do so.
Hopefully.
Yeah. Yeah, we'll see you soon.
So enjoy your weekend.
Thank you so much. See you guys.
See you. Bye.
Okay. Again, thank you very much to our speaker, Dr. Hannah Morisi and Professor Patrick Bol. And also thanks to Gita Laila as a moderator today. And yeah, the next agenda is the announcement of the prize recipients. And the recipient of the prize was based on the committee decision. Please, I invite Mr. Arde. Are you ready?
Ya, thank you. Tapi ini tadi ya, pemenang dari kita, dari yang bertanya hingga pemenang menjawab pertanyaan kuis gitu ya. Ada 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 pemenang ya. Hari ini 500.000, ratusan ribu kita bagikan gitu ya. Terima kasih atas partisipasinya hari ini, luar biasa semua dari pagi sampai sore. Nanti akan dihubungi oleh panitia karena bisa dijadikan pulsa ataupun GoPay ya buat order-order buka puasa begitu ya. Terima kasih teman-teman hadirannya. Semoga sehat selalu. Sampai berjumpa lagi di seri-seri selanjutnya.
Okay, thank you, Mr. Ade. And finally, we come to the end of the event. And again, thanks to our speaker, Dr. Hazliana Zainal, Dr. Hannah Morisi, and also Professor Patrick Bol. And thanks to our moderator today, Mr. Dimas, and also Gita Laili. And from the depths of my heart, I do apologize for my mistake in presenting this event. And thanks. Terima kasih untuk seluruh peserta yang sudah hadir hari ini, antusias yang luar biasa. Semoga apa yang sudah kita dapatkan hari ini, ilmu yang sudah di-sharing dengan oleh pembicara kita pada pagi. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Terima kasih, Bu.